Welcome back, ladies and gentlemen. We are now moving along to our next speaker. Normally, infertility is associated with women, but now we're talking male infertility. And we are going to welcome Dr. Mohamed. She is a specialist in the field of obstetrics and gynecology and consult at the BioART Fertility Center in Johannesburg. Welcome, Dr. Mohamed. You can take the stage.
Thank you. Thank you for the introduction, and good day to all the attendees. My name is Dr. Tasneem Mohamed, and I am from BioART, as mentioned. Thank you for the opportunity to present today. My topic is male infertility. Approximately 12 to 15% of couples struggle with infertility. That is roughly 1 in 6 couples. And of these, male factors are present in as many as 20 to 70% of all cases. Male infertility is frequently overlooked, with often the male being assessed only after the female has already been extensively investigated. And there's a vast spectrum of possible causes of male infertility. But before we begin talking about infertility, I'm going to take you through some of the basic anatomy and physiology so that you have a better understanding of the pathology and of how things sometimes goes wrong. Male reproductive organs include the primary and secondary organs. The primary reproductive organs include the gonads or the testes, which is responsible for sperm and hormone production, while the secondary organs include the ducts and the glands, which play a role in growth, maturation, and transmission of sperm. Sperm is produced in the Sertoli cells of the testes and is then released into the lumen of the seminiferous tubules. The sperm then travels through the retrograde testes and into the efferent ductules. The sperm then exits the testes and enters the epididymis. The epididymis is where the sperm is temporarily stored. It is also here that the sperm matures and achieves the ability to swim. When ejaculation occurs, sperm is propelled into the vas deferens. The vas deferens connects the seminal vesicles to form the ejaculatory duct. At this point, the sperm is mixed with fluid from the seminal vesicles. The ejaculatory duct penetrates through the prostate gland to get to the urethra. As such, the sperm ends up in the urethra, which then also receives substances from the bulbourethral glands. The sperm then exits the urethra in the form of ejaculate. Fluid and secretions from these accessory glands, namely the seminal vesicles, the prostate, and the bulbourethral glands, all assist the sperm by providing substances which will nourish and activate the sperm. It also makes the pH slightly alkaline to protect the sperm from the acidic environment in the male urethra and then the acidic vagina. Nourishment is needed in order to sustain the motility of the sperm through the uterus and the tubes until it reaches the egg. As the sperm passes through the fallopian tubes, they undergo 2 processes. 1, capacitation. This is where the outer layer changes, and 2, hyperactivation, which changes the way the sperm tail moves in order for it to be able to penetrate the egg. Now, contrary to popular belief, where we often say that it is the male who chooses the gender of the offspring, it is in fact the female. As many sperm, both X and Y, will attach to the outer membrane of the egg, but only one sperm will be allowed in by the egg, at which point the membrane then changes and becomes impenetrable to any other sperm entering. Now, let's discuss how sperm is produced. This process, while it occurs in the testes, is actually under the control of the brain. Gonadotropin-releasing hormone, also known as GnRH, is produced in the hypothalamus of the brain. This then goes to the pituitary, which is also located in the brain. The pituitary expresses a specific GnRH receptor. The binding of GnRH to this receptor triggers the production of gonadotropins, namely luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH. and these are then released into the bloodstream. In the testes, binding of FSH to its receptor in the Sertoli cells stimulates spermatogenesis, and binding of LH to its receptor in the Leydig cells initiates a cascade of enzymes that leads to the synthesis of androstenedione, which is ultimately converted to testosterone. Testosterone then begins its circulation through the bloodstream and serves to regulate GnRH, LH, and FSH production through what we call a negative feedback loop. Now, in the testes, this is where spermatogenesis is occurring. This is one of the most crucial stages in male fertility, and the slightest deviation from the natural course can lead to infertility. Spermatogenesis is the process by which haploid spermatozoa develop. This process starts with the mitotic division of the stem cells located close to the basement membrane of the tubules. These cells are called spermatogonial stem cells. The mitotic division of these produces two types of cells. Type A cells replenish the stem cells, and type B cells differentiate into the primary spermatocytes. The primary spermatocyte then divides meiotically through meiosis 1 into two secondary spermatocytes, and each secondary spermatocyte then divides into two equal haploid spermatids by meiosis 2. The spermatids are transformed into spermatozoa by a process of spermiogenesis. This is an animation of the process I have described.
Distinct spermatogonia.
Each cycle of spermatogenesis requires about 16 days, and then a further 74 days for the development and differentiation of spermatids into adult sperm. So the entire process can take as long as 90 days or 3 months.
Resulting daughter cells total 4 round sperms, by which a spermatid elongates, grows a tail or flagellum, and officially becomes a mobile sperm, is called spermiogenesis.
Now, onto the causes of male infertility. Well, there are multiple causes. It can be central cause, so related to the hypothalamic pituitary gonadal axis, psychological or sexual causes. It may be related to the reproductive organs themselves, so the testes or outflow tracts as discussed previously. It may occur as a result of infections, namely STI, sexually transmitted infections, urinary tract infections, viral infections, for example, mumps, and even TB, which is still prevalent in South Africa today. Iatrogenic causes, this means that it has been caused by previous medical treatment or as a result of medical treatment. Previous surgery, hernia repairs, surgery to the testes, bladder, urethra, or prostate, and also pelvic radiation for malignancy. Conditions such as diabetes, neurological disease, multiple sclerosis, spinal cord injury, cystic fibrosis are just a few medical causes that are associated with infertility. Medications or side effects of some medications can also cause problems with fertility. And lastly, genetic causes. Trauma to the testes, environmental exposure to toxins can also lead to infertility. And sometimes we don't find a cause at all. When we evaluate the infertile male, history is extremely important. Fertility history, sexual history, developmental history, past medical and surgical history, and of course, family history. Examination will include looking at the phenotype. This is the outward physical characteristics of the male. One will also look out for any syndromic features which may be present. Features of metabolic syndrome, so looking at weight, BMI, abdominal girth, all needs to be assessed. Assessment of the secondary sexual characteristics, hair distribution, and genitalia is important. Penis, testicular size, as well as where the testes is located. The semen analysis is the cornerstone of male infertility workup and includes the assessment of various parameters. The WHO reference range is used by most laboratories so as to standardize results. A few of the most basic components I will mention briefly include sperm volume. Here we would like a normal volume of between 1.5 and 6 moles. Sperm concentration, a normal concentration is more than 15 million sperm per mole. Total sperm count, a normal would be more than 39 million sperm. Sperm motility, this means the way the sperm moves. Normally, we need more than 32% to have a normal movement for us to have a normal motility. Sperm morphology, this is the form and structure of sperm or what they look like. The lower limit for percentage of normal sperm is 4%. Other parameters which are assessed, for example, include color, pH, viscosity, and any signs of infection. An increased number of white blood cells in the semen may be observed in patients with infectious or inflammatory processes. Other laboratory tests that may be helpful include the following: anti-sperm antibody testing, hormonal analysis, so your blood test looking at FSH, LH, thyroid stimulating hormone, testosterone, and prolactin, genetic testing, so karyotype to look at all chromosomes, or specific tests to look for cystic fibrosis and specific Y chromosome abnormalities or deletions, especially if the patient has asospermia, which means no sperm in the ejaculate, or severe oligospermia, very low counts, usually less than 5 million. Imaging studies that may be indicated include the following: transrectal ultrasonography, or sometimes scrotal ultrasound, and sometimes even vasography, which is kind of like an HSG for males. Surgical procedures are also indicated in asospermic men to further evaluate infertility and possibly also to retrieve sperm. This may be through testicular aspiration, epididymal aspiration, testicular biopsy, sometimes a true cut biopsy, and teaser or micro teaser. With regards to semen abnormalities, the common problems are those related to low volumes, low counts, low motility, and low morphology. However, more recently, it has been noted that the basic semen analysis may not be able to identify all sperm pathology. And of late, there has been a lot of discussion and research regarding sperm maturity and DNA fragmentation. The most devastating diagnosis regarding sperm count is, of course, asospermia, as this means no sperm. In these patients, various investigations will be conducted in order to differentiate between obstructive and non-obstructive causes. For the obstructive causes, they can be helped via surgical sperm extraction techniques, followed by ICSI, which means intracytoplasmic sperm injection. Okay, so this brings us now on to treatment options. Treatment is tailored as to the cause. For certain endocrinopathies, low sperm morphology and counts, medication, supplements sometimes may be prescribed. Also, in the case of infection, antibiotics, for example, may be indicated. Surgery is sometimes performed in certain cases of varicocele and hydrocele, but this too is contentious. Lifestyle modification is important and cannot be overemphasized. We know that smoking, excessive alcohol ingestion, illicit drug usage, anabolic steroids can all affect sperm parameters. Weight, BMI, exercise, diet, maintaining appropriate testicular temperature by avoiding tight restrictive clothing, hot tubs, saunas, etc. are all to be considered. And then there's assisted reproductive therapy technologies, which is where the fertility clinics come in. Here we can assist with surgical sperm retrieval, electroejaculation in cases where normal ejaculation cannot occur, for example, in cases of spinal cord injury. Assisted reproductive techniques which may be employed include artificial insemination in your minor male infertility cases, and then IVF and ICSI with more severe cases. Then lastly, for the male with non-obstructive asospermia, this diagnosis is usually confirmed on teaser, and here too there are variable grades. The Johnson scoring system is a histological grading system commonly used, with 1 being the most severe form. These men often have small testes and raised FSH and LH levels with low testosterone levels, indicating testicular failure. And traditionally, these men, especially those with a Johnson's score of 7 or less, would be offered the use of donor sperm. However, stem cell therapy in this field is promising, and we at BioART have used stem cell therapy for the treatment of such cases and had success with sperm retrieval following such therapy. And we now also have 2 ongoing pregnancies to date. I thank you for your attention.
Thank you, Dr. Mohamed. Wow, that was really, really an interesting topic. And we always love to talk about male infertility. Not many males, as we know, like to talk about their infertility. So we'll also chat a little bit about how we can increase that and break the stigma a little bit around
Correct.
it.
But I think it was very interesting to see that it was a female talking about male infertility today. So I think, yes, we do need to break the stigma around male infertility, and I think the more we talk about it, that's hopefully one of the ways that we're going to get through.
Exactly.
Yes.
So I'm going to go straight into the questions. Please, can you talk a little bit about DNA fragmentation and the efficacy of antioxidant treatment?
Okay, so as I mentioned in my slide, it is something that we're looking, or that has been looked at now more recently, because sometimes we find that the semen analysis, basic semen analysis is normal, yet we're having problems with fertility, poor fertilization rates, etc. And looking at DNA fragmentation, this has been found to maybe be a reason as to why we're still not getting good pregnancy rates or good fertilization, and we're thinking if that might be the reason for the male factor that hasn't been accounted for. So DNA fragmentation, one of the common causes of what causes DNA fragmentation is oxidative stress. Okay, and that's where your antioxidants come in. So antioxidant is to now improve that, so to basically counteract the oxidative stress. So there's many supplements on the market now that include antioxidant therapy. This is to reduce inflammation, improve blood flow, and in that way hopefully reduce the oxidative stress and reduce DNA fragmentation. There's also other treatments. There's also been some research and studies looking at male with very bad fragmentation, DNA fragmentation, to rather do or testicular sperm extraction and using that sperm for fertilization as opposed to your ejaculate sperm, because we also know that through the maturity process, passing through the epididymis, the maturation process, that's where DNA might become fragmented or oxidative stress might occur. So by taking the sperm from the testes, even though it's slightly immature sperm, we might have less DNA fragmentation and get better results. So that's one of the...
So that actually, it goes to one of the questions that are coming now about the supplements on the market. There are many supplements on the market.
There's many, and obviously different doctors will have their favorites, different clinics will have their favorites, and I don't think we're meant to be talking really about which ones we prefer, but there are many, and I think it's important that you just check what supplements you're taking. Look at, some of them have research behind them, and I think those are the ones that we should be promoting. And there are a lot of good supplements on the market, and not only for males who are known with sperm abnormalities, but even just couples who want to try conceiving. It's not a bad idea just to start a supplement, both male and female, to make sure that you're not just deficient. Most of the supplements just have vitamins, minerals, micronutrients, your selenium, your zinc, which we might be deficient in our diet, and it's definitely not harmful in any way and can only help.
Okay, excellent. So we've got 5 eggs left to fertilize for IVF through surrogacy. I obviously want to increase my chances in the best possible way. So does that lead into what you were talking about with potentially taking the mature, this is with defragmentation in his
He's got
sperm.
fragmentation.
Yes.
Okay. Well, not only does it have to be testicular sperm, there's other ways that the lab can also try and choose the best sperm. Okay, so ICSI, and now there's also PICSI, which is physiological ICSI. There's so much new research coming out just so that we can select sperm better. But I think that is maybe something that this particular patient would want to discuss with their clinic, discuss with the embryologist, andrologist, and basically just look at the options that might be offered to them.
Okay. So a study I found suggests that our results indicated that in patients with previously unsuccessful oral antioxidant treatment, the retrieved testicular goodness, they're putting me through my paces today. Sperm had a lower degree of DNA damage compared with ejaculated sperm collected on the same day.
Yes.
So that's what we talked about, the
that's
testicular sperm retrieval.
Yes. Yes.
Okay, excellent. Okay. All right, so how do you deal with retrograde ejaculation?
Okay, so we suspect retrograde ejaculation usually when we see that there's a very low volume of ejaculate. Okay, usually after ejaculation, we can then test the urine and look to see if there's sperm in the urine, which will then confirm the diagnosis of retrograde ejaculation. However, as mentioned also in my talk, urine is acidic, so that's harmful to the sperm. But there is ways that we can prepare the patient, we can prepare the bladder so that we can actually get the sperm from the bladder after ejaculation, retrograde ejaculation, and use it for assisted reproductive therapies. So in this way, we can ask the patient to void first, so empty the bladder. We can then even irrigate the bladder, sometimes instill some culture media into the bladder, then have them ejaculate, and then retrieve the sample sterilely with catheterization, which will then go to the lab, and they need, obviously there'll be a little bit of urine in there, so they do need to act quickly and to prepare the sample, wash the sample, and prepare it so that it can be used for assisted reproductive therapies.
Okay. So this is also another question. This is what was in their report. Consider short abstinence in conjunction with low density gradients in future ART cycle. This was in my report. What does this mean?
So I'm assuming they're asking like a short abstinence period,
yes.
Right? So the longer the abstinence period, you're going to have a lot. So usually,
between
ideally,
ejaculations,
between ejaculations, the longer the abstinence period, you're going to have a lot of dead sperm. You'll have probably a higher volume, but not very good quality. And then two short intervals between ejaculation. Again, you're going to have then a problem of volumes and concentrations, or volume rather, and counts. So there's usually an ideal interval, which when we want to do a semen analysis, it's 3 to 5 days. It's now extending it between 2 and 7 days. But for IVF and insemination, ICSI procedures, usually a 2-day period of abstinence is sufficient.
Okay. Perfect. All right. So what is the relationship between old age and sperm quality?
Okay,
so we know that when we get older, we get painful eggs. So with regards to
even though the age thing is, we usually focus more of that onto the female, saying that there's this biological clock, tick, 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 and as you get older, it's going to become harder, which is a known fact, right? It is because women are born with the eggs and they get finished over time, and men, it's the same applies, but to a slightly lesser degree because they're producing sperm on a continuous basis. But there is an association with reduced sperm parameters and quality and increased age. And also probably because of other comorbidities that creep up as we get older. The hypertension, the diabetes, and all of that will also then affect the sperm parameters. So yeah, we do with older men, there are reduced fertilization rates with sperm from older men, as well as blastulation rates, things like that. So yes, there is an association.
So it's not just us.
Not just us.
That's what you're saying. Great. Undescended testes and malignant risk. What age is this generally related to?
Undescended testes, there is an increased risk of malignancy, and this is known, okay, which is why a child has undescended testes. Usually they need to operate to bring the testes down, and ideally this needs to be done before the age of 2, at the age of 2, and this is to firstly reduce the risk of malignancy, and secondly also if the earlier it's done, the better for the future fertility as well. But yes, so there is an association with malignancy, and it's usually because the testes is in the wrong place, so it's exposed to higher body temperatures, and that can promote malignancy from develop.
Okay, so now we want to talk a little bit about how we get more men involved in breaking the silence around male infertility. So as we were talking about previously, we only have 1 or 2 men that we can actually call on who've been through male infertility when we get requests for radio interviews or any press involvement or any talks we want to give from a patient perspective versus from a specialist perspective. Now, what is the percentage of female fertility versus male fertility versus what is the percentage? Is it equal or is it more?
Well, there's actually a very high percentage of male infertility, okay? So usually we look at female causes, male causes, combined causes, and unexplained causes.
Yes.
And male can actually form up to 40% of your male infertility causes. And I mentioned in one of my slides that amongst our infertile couples, 1 in 6, 20 to 70% can have an associated male infertility. So it is a high percentage, and it, like I also mentioned, it's often overlooked.
Yes.
And usually we'll be investigating the female. Sometimes the male isn't even there for the first consultation, second consultation, and eventually we need the semen analysis, and that's when we pick up that there's actually a male factor.
So we need to encourage the couples to go to get checked out by specialists as a couple.
Yes.
Because, as you said,
it's a couple problem, not a female problem, not a male problem, it's a couple problem.
Exactly. Yes. And there's nothing to be embarrassed about. I mean, it was back in the day, it would be because then in certain cultures, they get told to take another partner. Wife, yes. Yeah. My brother will do it, it's fine. And that's not really acceptable conversations to be having, because with couples, it's a couple problem, 40% we've heard. So we need to promote that it's normal. We need to have these discussions. We need to have men that are willing to talk about their infertility, even if it's with their partner. They talk together, because, as we said, a partner problem. You get married not just to have children. You get married because you love your partner. So whoever is the infertile person in the relationship, it's still a couple problem. So we need to make it more of a normal conversation to have. And as you mentioned, a female talking about male infertility.
Yeah.
Do you find when you have patients come to see you and it is the male, will they be less likely to want to have you as their specialist?
No, actually, strangely not.
Good.
I think some of them actually prefer it, maybe because they feel also shy to talk about it with the male partner. They might just feel that, okay. But strangely not. In fact, I often get a lot of male patients by themselves coming in to consult, which is good. Maybe we're breaking some barriers there. Yeah.
Yes, so we are making strides forward. Great. Okay, so if you haven't asked your question for Dr. Mohamed and you'd like to ask her via email instead, please do email fertility@liveevents.africa. We'll pose your questions to Dr. Mohamed, and then she'll get back to you, we'll get back to you, you'll get your answer if you're too shy to come forward on this platform. But please, guys, please do not be shy. Please talk to your friends about it. It might be happening to them too.
Absolutely.
Thank you, Dr. Mohamed. We appreciate you coming through.
Thank you.